Thank you, Dr. Rai. So I'm going to highlight the recent approval of Venetoclax by the FDA in 2016. So basically, the list of approved agents for CLL is quite extensive, and this list certainly may not be 100% accurate, but as you can see here, going all the way back to chlorambucil, there's a large array of choices from which we can choose what to treat our patients with. While I call this a banner year for CLL, we've actually only had 2 drug approvals in all of oncology this year, and only 1 in CLL. So the question, of course, is how is this a banner year? And that I'll hopefully be able to answer by the end of this presentation. So currently there are a large number of Venetoclax trials that are ongoing, and they're actually being run from a multitude of different companies and organizations. So here we have the M13982 trial, which is actually the pivotal study that led to the accelerated approval of Venetoclax, and that's what I'm going to speak to primarily today. But I would like to highlight the other trials which are ongoing, including Venetoclax plus rituximab in relapsed CLL, Venetoclax post-BCR Antagonist, which I will touch on today as well, bendamustine followed by Venetoclax plus obinutuzumab in CLL, and this is being run by the German CLL study group, and it's being called triple therapy. And the idea, of course, is to use the bendamustine to help debulk the patients and to make the Venetoclax risk of tumor lysis less. We have Venetoclax plus obinutuzumab, which is being run by Genentech or Roche, which is, in similar terms, the obinutuzumab is being used to help debulk the tumor and diminish the risk of tumor lysis. Ibrutinib followed by Venetoclax, which is being run by Pharmacyclics, which also is here using Ibrutinib to help diminish the risk of tumor lysis with Venetoclax, as well as taking advantage of a synergy by having the cells out of their protective niches in the microenvironment and perhaps increasing their sensitivity to BCL2 inhibition. This is actually of note being done in untreated CLL patients. Then we have the Roche study, Genentech plus rituximab versus BR in relapsed CLL. And then we have Venetoclax plus BR versus Venetoclax plus BO. And then we have Venetoclax plus obinutuzumab versus obinutuzumab plus chlorambucil in untreated CLL patients who are considered unfit for chemotherapy because of a SEER score greater than 6, which is being done by Roche. So we have a large number of trials being done across the world, which will actually give us, I think, a lot of important information on how to use Venetoclax safely and to the best of our ability. So this is here what I am focusing on. My daughter helped me with that because she said my presentation was boring. Here we have Venetoclax's mechanism of action, and we have all seen this slide very frequently. And really, it's just important to recognize that Venetoclax, by binding to BCL2, is able to interrupt the normal BCL2 family member partnering, which plays an important role in keeping the cells alive. So by freeing up, or by actually binding BCL2 as an anti-apoptotic protein, it allows the pro-apoptotic proteins that are left to be free to actually pair with one another and induce pores in the mitochondria and lead to mitochondrial membrane depolarization and cell apoptosis. Very important to remember that this really is a P53 and a BCR independent process, and for that we really end up with a very powerful agent in some very difficult scenarios. So Venetoclax is dosed once daily, and it's oral. And what I'd really like to emphasize is that a lot of the issues in the early clinical trials related to tumor lysis, both clinically and biochemically, have been mitigated with a new tumor lysis strategy. I'm going to spend some time on this because it's important to appreciate it. So the original study was done as a typical phase 1, starting off at 20 milligrams orally and then escalating up the dose, and they actually went as high as 1,200 milligrams daily. There were 2 deaths due to tumor lysis, one of them even after the first dose of 50 milligrams of Venetoclax. So of course, this is something to be very careful of and consider it closely. But I would like to report that since this tumor lysis mitigation strategy has been put into place, we've actually had no clinical cases of tumor lysis and only a few very mild cases of chemical tumor lysis. So the oral dosing schedule is 20 milligrams daily for 1 week, escalate to 50 milligrams in those patients who are not showing any chemical signs of tumor lysis, followed by an escalation a week later to 100 milligrams, once again, for those patients who aren't showing any evidence of tumor lysis, followed by an escalation to 200 milligrams, and then 400 milligrams, and then, of course, remaining on 400 milligrams until unacceptable toxicity or progressive disease. And the key here is to always make sure before you escalate the dose that the patients have no evidence chemically of any tumor lysis syndrome. Now, it's important to also keep in mind that there were some variations in the actual prescribed tumor lysis mitigation strategy and the dosing schedule. So some of the early studies had day 1 dosing of 20 and then day 2 of 50. We've also explored some rapid dose escalation protocols for patients who are rapidly progressing and need to get rapid disease control. But this is the actual recommended dosing schedule in the package insert. So the other key component to the tumor lysis mitigation strategy is actually assigning patients a risk of tumor lysis based upon the lymph node size and the lymphocytosis. So patients are divided into low, medium, and high risk of tumor lysis based upon having lymph nodes of less than 5 and a ALC of less than 25, or having lymph nodes 5 to 10, or an ALC of greater than 25, or high based upon having lymph nodes greater than 10 centimeters, or an absolute lymphocyte count of greater than 25, plus a lymph node size greater than 5 centimeters. And this is based upon early clinical studies data. So this is all data-driven. And here you can see your recommended prophylaxis with oral or intravenous hydration, as well as uric acid inhibitors, namely allopurinol or allopurinol plus rasburicase. And then here they have the recommended monitoring. What, of course, is most significant here is the monitoring can be outpatient for low and medium, whereas hospitalization is absolutely recommended for the first dose of 20 milligrams and 50 milligrams at those dose levels. And then, of course, for patients who might have other issues, either a slight decrement in their GFR or an inability to orally hydrate, or they have still persistent high tumor volume, certainly omitting them for subsequent dosing is an option. So the study we're now going to talk about, the pivotal study, is the M13982 study, and this was published in Lancet Oncology, led by Stefan Stilgenbauer. And basically, it was Venetoclax monotherapy in patients with relapsed CLL who had 17p deletion. Key inclusion criteria, of course, were relapsed CLL, 17p deletion, an ECOG performance of less than 2, an ANC of greater than 1,000, and a platelet count greater than 40,000, hemoglobin greater than 8,000, and a creatinine clearance of greater than 50. So that's also an important thing to consider when thinking about using Venetoclax. Key exclusion criteria include autoimmune cytopenias that were not well controlled and prior allogeneic transplant. Here you can see the baseline characteristics. What I really want to highlight are the relative percentages of the low, medium, and high categories. So 16, 40, and 42 for low, medium, and high. 18, 40, and 42 for low, medium, and high. Really showing what might be a very true breakdown of tumor lysis risk in our patients. One of the questions, of course, that I think we need to keep in mind going forward is that if someone clearly is moving in the direction that they're one of these CLL patients are going to be progressing and they're 17p deleted, we actually may have a good justification now for initiating treatment earlier in those patients before their tumor lysis risk gets to the high category. And that's something that I think clinically we should all keep in mind as we move forward. So the overall response rate based upon the independent review committee was 85%, was 79.4%, with 7.5 CRs, 2.8 nodular PRs, and 69% PRs. Now, 25 out of the 48 patients who were assessed had no CLL in the bone marrow, and 18 out of the 45 patients who were assessed were MRD negative in the peripheral blood. So it's important to remember that when we're looking at MRD negativity, of course, peripheral blood is less sensitive than bone marrow. And in the, with the use of an anti-CD20 monoclonal antibody, of course, which was not used in this study, we actually have an impact on the ability to assess MRD. Here you can see the cumulative incidence of response, and I think that this is really quite interesting, the way you see the responses very early on. So really, almost everyone has declared themselves as a responder and by month 6, and that's something that will become helpful later on. And when you look at CRs, we see the CRs actually begin to be identified by month 12. And one of the important questions is going to be how this curve changes going out, and whether or not we would know by month 12 whether or not our patients are going to be one of those who've had a tremendously deep response that will be able to last for a very long duration. What I'd really like to also warn everyone about with Venetoclax is this idea of an MRD negative PR. A lot of these patients will start with very large lymphadenopathy that will shrink very slowly, and in essence keep them a PR long after they might be MRD negative in the peripheral blood and bone marrow. So in essence, I really personally use MRD status as a much better indicator than the IWCLL response, though I'll show you data otherwise in a moment. But the idea being that it's important to keep in mind that there is definitely going to be a disconnect, and that we might see our maximal response long before we actually record it with our standard clinical trial criteria. So median time to first response was 0.8 months, and the median time to CR or CRI was actually 8.2 months. Of 45 patients that were tested, 18 achieved MRD negativity in the blood, and you can see here the time to MRD negativity, and I apologize for the months not printing out here, but this is 6, 12, and 18. You could see here that we've really start seeing MRD negativity before month 6. So the patient disposition, how are these patients doing long term? So the median time on study was 12 months. 70 patients, or 65%, were still actively on Venetoclax. 22 had disease progression, and that was split half to Richter's transformation and half to CLL progression. And I think that this is a very important caveat to keep in mind, that it looks like what may happen is that if you don't achieve a very deep CR, you are going to progress within about 12 months. And so really, that CR rate becomes very important for patients on Venetoclax. And when we look at the different studies, keeping in mind the number of patients who are achieving this MRD negativity, which right now currently is going to range between 50 and 75%, based upon whether or not this is a relapse refractory or a 17p deleted study, really can help guide how patients are going to do long term. 9 patients withdrew for adverse events, 3 went on to stem cell transplant, and you can see that there were 18 deaths, 14 of which were due to progressive disease. So overall, you can see the absolute change in lymphocyte count from baseline, and of course there was a tremendous response in almost all patients. Likewise, the nodal response here, you could see there was also a tremendous change in most patients. I once again would like to emphasize that, remember, a lot of these patients are going to be what really in essence are MRD negative PRs, and so these data do lose a little bit of meaning compared to when we're using chemotherapy. And now the durability of response. Here you can see duration of response with 12-month estimates of all responders being 84%. CRs is 100% at 12 months, and this is what I was referring to, where actually the CRs did better than the MRD negative patient population. But I sort of wonder if we were really to wait on a lot of these MRD negative patients that weren't CRs, they will get CRs due to just continued shrinkage of what are probably non-involved lymph nodes. Here you can see the PFS and OS. We talk about a 72% 12-month progression-free survival with an overall survival of 86.7%. So obviously very impressive in a patient population that is relapsed and refractory 17p deleted, especially when you think about the number of patients who are getting MRD negativity and how these MRD negative patients are doing. Treatment-emergent adverse events, the drug was well tolerated. I really think neutropenia and diarrhea are the two most likely disease-related drug-related symptoms that we'll contend with as physicians. But the adverse events of special interest, I just want to go into the grade 3-4 neutropenia was seen in 40% of the patients, but 22% of these patients had baseline neutropenia, and it really was manageable with either dose interruption or reduction, so it did look like it was dose-related, or just the use of prophylactic antibiotics or GCSF. Infections were seen in 72% of the patients, and remember that these were 17p deleted patients previously treated, so a lot of them had gotten chemotherapy and had significantly received, really had their marrows significantly beaten up. But the most common were just URIs and urinary tract infections and upper respiratory tract infections. Laboratory tumor lysis was seen in 5 patients during the ramp-up, 2 with a dose interruption, but there were no clinical episodes of tumor lysis, and that is the most important thing. And serious adverse events were seen, but you can see them here. So that's the pivotal study that led to the approval, but I want to talk about another study that actually may really help play a role in positioning single-agent venetoclax in patients in the day where most patients might be getting a ibrutinib or Idela as their frontline therapy. So the M14032 study, which was presented by Dr. Jones at ASH, looked at venetoclax in patients who had received a prior BCR antagonist. So there are 2 arms to the study, which are looked at separately, ibrutinib and idelalisib. And the key inclusion criteria were progressive disease during treatment or after discontinuation. So it's important to remember that not all these patients were refractory to their BCR antagonists. So patients who had a response and then came off the drug for other reason and then progressed were actually enrolled in this study. So that's an important difference between a lot of what we hear about the BCR progressors, BCR antagonist progressors. Here you can see the patient populations. I'm just going to quickly mention, just call out the median time of prior therapy on ibrutinib and idelalisib in each arm. So these are the ibrutinib treated patients, these are the ibrutinib arms, and these are the idelalisib arm patients, but a lot of these patients had both agents before going on, and so that generates why there's prior Idel and idelalisib, ibrutinib and idelalisib in both arms. You can see here the disease burden characteristics. So when we talk about absolute lymphocyte counts, 39% of patients had an ALC greater than 25, and 17% had an ALC greater than 100,000. And it's significant to know that in the BCR antagonist populations that are relapsed, we often do see a very rapid rise in lymphocyte count as the BCR antagonist is held. So patients did have to come off the BCR antagonist before going on trial, and so that did allow for a lot of time for this rapid progression. And here you can see the bulky disease patients, and I would like to just point out the prognostic markers. You know, obviously this was a very heavily pre-treated patient population, with 36% of the patients having a TP3 mutation and 46% having deletion 17p in the ibrutinib arm. The numbers, of course, are a lot smaller for the idelalisib group. And here you can see the overall response rates, a 61% overall response rate for the ibrutinib arm and a 50% for the idelalisib arm, with 3 CRs and 20 PRs in the ibrutinib arm and 5 PRs in the idelalisib arm and no CRs. And here you can see the swimmer's plot looking at the basically the number of patients still on active treatment. So you can see those patients who develop progressive disease while most of the patients have remained on therapy. And then likewise, here's the swimmer's plot for the post-idelalisib group of patients, where you can see the 2 patients who discontinued therapy while everyone else remains on therapy. So these data will mature, and of course, that's going to be very important, especially when you think about the number of patients who are here that haven't gotten to the 1-year mark. This was also well tolerated, with neutropenia and nausea and diarrhea being the most common adverse events. And so in the last minute, I'd just like to talk where we might be able to use venetoclax in our current patients. So here we have 2 studies, one the pivotal study looking at 17p deleted CLL, the other actually looking in patients post-BCR antagonist. So this is a curve from the Blood 2015 paper, the 3-year follow-up on patients treated with ibrutinib. So this is the 1102 study, the treatment-naive population as well as a relapse refractory population. At ASH, we're going to see the 5-year update to this data. But what you can see here, that the patients who get ibrutinib as their first-line therapy, and remembering that this was a deletion 17p patient, if they're not 17p deleted, they're going to do extremely well. This patient developed a Richter. So let's take this as the demonstrative patient who basically had a 17p and then had a large tumor burden, and basically over time, those additional hits occurred that might have led to the Richters. And we know that our BCR antagonists are ineffective by and large in Richter's transformation. So in essence, how can we make this curve more like this curve? And the idea would be perhaps intervening before we get to this point in time where the second hits cause these cells to either transform into Richters or before they actually have a chance to develop resistance based upon some of the mutations that we heard earlier. The one caveat I'd like to point out is we're still not clear whether or not these mutations are pre-existing or not. If these mutations were pre-existing, we would expect to see some level of progression in this relatively prognostically good population of patients. So those are going to be very important data to look at. But what you could see here is out of 308 patients, 10% discontinued due to disease progression, almost split 13 patients with CLL and 18 with Richters. And so the question is, can we identify these Richter's patients ahead of time? And I just want to draw attention to 2 groups that I'm very particularly interested in. One is the V gene use 4-39, which has a 3.14 increased risk of developing Richters, and then a Notch1 mutational status, which is a 3.71. And when you look at the 5-year risk of developing Richters in these patients, so for Notch1 mutation, it's 18.6%, and the 15-year risk is 45%. Now remember, there are a lot of other issues related to the amount of chemotherapy these patients received in their lines of therapy. For 4-39, the 5-year risk is going to be 35.4% versus the 5.6%. But these risks are additive. So when you get to someone who's mutated with their Notch and has a 4-39, you're talking about a 75% chance of developing a Richter's transformation at 5 years. So the question becomes, in these patients, are we dealing with a time bomb? And that if a rapid response is necessary, and ibrutinib, which is highly effective but induces a slow response, it would seem to, and the patients who have good prognostics and can sit and wait for their complete response to arrive at year 5, maybe for these other patients, waiting is what's the problem. And so if we were to initiate early therapy with ibrutinib plus something like venetoclax to dramatically reduce the number of tumor burden and hopefully diminish the risk of those second hits happening, we can have a real impact on these patients' outcome. Thank you.